Welcome to my presentation, ARDS Management, New Updates. My name is Terrence Shenfield and I am the co-owner of A&T Respiratory Lectures. This presentation will bring you up to date on ARDS management based on the most current studies. Today's presentation will, number one, describe what is acute lung injury or ALI. It will describe what is ARDS. It will describe the clinical picture of ARDS and ALI. It will describe some treatment options, especially in regard to mechanical ventilation. And then I will talk about a case study with this. Acute lung injury and acute respiratory distress syndrome are life-threatening diseases in a critically ill patient. They are the manifestations of an inflammatory response to the lung, both direct and indirect, and results in characterized hypoxemia, hypercapnia, diffuse infiltration in chest X-ray, and a substantial reduction in pulmonary compliance. As part of the therapy, mechanical ventilation is critical to resolving hypoxia and hypercapnia. However, studies have shown that mechanical ventilation, if not properly used, will further damage the lungs due to overinflation, barotrauma, and cyclic closing and reopening of the alveolar. This phenomenon has been named ventilator-associated lung injury, or VALI. Furthermore, the mechanism of VALI can cause pulmonary and systemic inflammatory reaction, which can lead to multi-organ failure. ARDS is an acute inflammatory condition of the lungs and is due to some underlying disease process or trauma. There's around 150,000 cases each year. The mortality rate is really high, sometimes up to 50%, even 60%, all depends on the cause. The most common reasons is sepsis or trauma. And the clinical setup is that you get an acute onset of respiratory failure. Your X-ray will show bilateral infiltrates. You have to rule out left ventricular failure to make sure it's not cardiac pulmonary edema, and the PF ratio is less than 200. These are all the signs of ARDS. I want to further differentiate between ARDS and ALI. ALI is acute lung injury, and basically it follows the same criteria of ARDS, but the PF ratio is less than 300. So to differentiate between ARDS and ALI, in ARDS, the PF ratio is less than 200. In acute lung injury, or ALI, it's less than 300. ALI is a less severe form of ARDS. In ARDS, there are two types. One is called primary, and the second one is called secondary. When you think about primary injury, this occurs in 70–80% of all cases. And the most common cause of ARDS primary is pneumonia. This occurs at 40–50% of the time. Other ways that ARDS can occur is aspiration, pulmonary contusions such as chest trauma in a motor vehicle accident, inhalation of toxic gases, and near drowning. I worked for a major trauma center in my career, and we had a lot of automobile accidents, and as a result we had a lot of pulmonary contusion, and so many cases of patients who developed into ARDS came from chest trauma. So this is called primary ARDS. Indirect ARDS or secondary ARDS occurs around 20–30% of the cases. And the most common cause of this is systemic inflammation, and this is caused most likely by infection. A lot of times patients who become septic or have a peritonitis, they end up getting ARDS secondary to the infection. Tissue ischemia, such as necrosis or pancreatitis, are another example of secondary ARDS. And finally, some patients who suffer tissue damage as a result of trauma or a CABG or post-op. All of these patients sometimes develop ARDS, and this would be considered secondary ARDS. I wanted to discuss some of the risk factors of ARDS. Studies have shown that advanced age is associated with increased susceptibility of getting ARDS. Age has also been recognized as one of the major determinants in predicting morbidity and mortality in this population. Even though elderly patients usually have more comorbidities, this only partially explains their higher mortality. One of the biggest problems is tissue injury. Tissue injury is modified as we get older, and studies have shown that there's age-related changes to our immune system. Another problem is the increased release of pro-inflammatory cytokines and chemokines as we get older, resulting in dysregulation of the activation and migration of inflammatory cells and endothelial dysfunction. All of this increases the mortality of ARDS patients. When we think about infection, pneumonia is at the top of the list. Pneumonia is one of the most common causes of ARDS, and it still is. When you think about neurological diseases, which I'm talking about the neural ICU, mechanically ventilated patients in this unit are at higher risk of getting ARDS. Some of the reasons could be loss of gag reflex. It could also be lower brainstem dysfunction. All of these are clinical factors of increasing the risk of ARDS. This warrants extra protection when a patient is intubated and manipulating the ET tube. You should do good pulmonary suctioning and also make sure that the patient doesn't aspirate. Let's talk about the clinical picture of ARDS. Some of the most common signs are cyanosis, also tachypnea, the patient has high respiratory rates, dyspnea, the patients are very short of breath, and crackles. When you think about crackles are normally associated with inflammation or infection of the small bronchi. But crackles with ARDS are as a result of pulmonary edema and don't clear on a cough. Extrapulmonary manifestations include insults that affect the vascular endothelium, and this is caused by inflammatory mediators that are released through the bloodstream. Let's talk about the pathophysiology of ARDS. The acute phase of ARDS is characterized by injury to the alveolar capillary barrier with disruption leading to increased permeability and leakiness of the alveola. Leukocytes accumulate in the pulmonary capillaries and then invade the airspace. The consequences include inflammatory vasoconstriction, reduced compliance where the lungs become very stiff, atelectasis as collapsed alveola become more prominent, and this is due to a loss of surfactant, and at this also the lungs become very stiff. The consequent respiratory failure is aggravated by severe ventilation perfusion mismatching, with some perfused alveola receiving no ventilation while others receive no perfusion and resulting in dead space. The three phases are also recognized in the evolution of ARDS, and that is called the initial acute phase, which is consistent of non-cardiac pulmonary edema. The second phase, which is typically 1 to 2 weeks, is an inflammatory response where you have interleukin-4, interleukin-13, and this promotes collagen deposition. Then you have the organization of hyaline membranes, and during the third phase, this is when the lungs become fibrotic, and this is really a real severe state of ARDS. With time, this can lead into fibrosing alveolitis. The lung compliance of the patient really decreases, so this is a good time to monitor compliance of the patient. Patient could progress into pulmonary hypertension, which can lead into right heart failure. The resolution of ARDS is typically 6 to 12 months. Lung function can return to normal, but some patients have long-term deficits in their lung function, and the overall mortality of ARDS is over 50%. So this is a severe type of injury to the lungs, and sometimes lifelong consequences are involved. Here's a listing of the pulmonary insult to the lungs. Number 1, interstitial and alveolar edema. Because of the flooding of fluids into the alveolar space, the alveolars become full of fluid, and it makes it very hard to oxygenate with all that fluid in there. This causes an increase in extravascular lung water, where some water escapes out of the alveoli and goes into third spacing. This increases the stiffness and weight of the lungs. The lungs become pretty consolidated with fluid, and there's very little room for oxygenation. There's a term they call compression atelectasis. Compression atelectasis is where the alveola become collapsed and full of fluid, and this is more in the caudal sections of the lung, the lower lung, parts of the lung, and a lot of patients who are in a supine position need to be proned at this point. There's a reduction in compliance where you could serially see compliance decrease in a patient. We always used to measure compliance every day on our patients like that to make sure if they were getting better or getting worse or plateauing. Also, there's a decrease in functional residual capacity, which equates to poor oxygenation. And there was a lot of intrapulmonary shunting, which, again, has a whole problem with the oxygenation of the patient, tissue oxygenation. With ARDS, you need to do a diagnostic workup, and that consists of a medical history, a chest x-ray, and doing an echo or a PA catheterization. In regard to the medical history, you look for predisposing factors that could lead to ARDS, such as a blunt trauma to the chest, infection such as pneumonia, blood transfusion, inhalation of toxic fumes. All of these can lead into ARDS. Basically, when you look at the chest x-ray, you're going to get bilateral infiltrates. It becomes a very common pattern on the chest. And you need to actually do an echocardiogram or a PA catheterization to determine that the pulmonary capillary wedge pressure is less than 18. And the reason for that is that you will get pulmonary edema with ARDS, but you have to rule out left ventricular dysfunction. This is the typical x-ray of a patient in ARDS. And according to the latest definition, the diagnosis is based on the onset of hypoxemia and of bilateral chest opacities within 1 week of the known risk factor. So basically, if someone's in a car accident and they have some chest trauma, if within a week their chest x-ray goes from basically a clear x-ray to this, you can strongly consider that the patient has ARDS. Another thing you could possibly do is a CAT scan. A CAT scan is just as good as an x-ray in determining whether you got ARDS. Persistent lung inflammation, increased vascular permeability are all part of the picture, and this results in poor gas exchange. Another part of the diagnostic workup is looking at the ABG. And what's really important is to look at the PF ratio. The PF ratio, as you know, is your PaO2 divided by your FiO2. If your value is less than 200, you have ARDS. If your value is less than 300, you have acute lung injury. The hallmark signs, typically at first you become hypoxemic due to the poor oxygenation. And you also become hypocapnia. So why are you becoming hypocapnic? And the reason for that is there's a lot of anxiety when your respiratory system is not working properly. When you feel it's very difficult to breathe and take some deep breaths and you're not oxygenating well, you're going to experience anxiety. And when you have anxiety, you're going to have an increased ventilatory drive, which you're going to blow off all your CO2. Eventually, you're going to tire And as a result of tiring, your respiratory rate's going to go down, your tidal volumes are going to go down, and you're going to end up being in respiratory acidosis. When you get into respiratory acidosis from tiring, that is most likely the time they're going to intubate you. Now let's turn our attention to early management of patients with ARDS. So you have a patient who was in a car accident, they have a blunt chest trauma. You do a workup on an x-ray, you start seeing opacities come in the x-ray, you also see an increased ventilatory drive, and the oxygenation status based on the PF ratio is getting kind of poor. At this point, you may want to consider some ventilatory support. How about the use of non-invasive ventilation in ARDS? There has been some studies showing that it does work with mild ARDS. So in other words, if someone has a PF ratio under 200, no, non-invasive ventilation is going to probably not work. But if you have someone with a PF ratio between 200 and 300, yes, possibly non-invasive ventilation will work, but you got to really watch. Some of the criteria is that the patient has to be fully conscious, they have to be cooperative, they have to be hemodynamically stable, they have to be able to come off the mask and possibly eat and drink some fluids. They have to be able to take some decent tidal volume, some decent breaths. If you put someone on non-invasive ventilation and you don't see any improvement in their PF ratio, and say I'm talking about a PF ratio of 200, 225, and you put them on for 1 hour and they don't do better with the non-invasive ventilation, that's the time to intubate. Many studies have shown that if you keep someone on non-invasive ventilation for a prolonged period of time, this can cause further damage to the patient and actually increase the mortality. Let's take this a step further in regard to the management of patients on mechanical ventilation. So many patients who initially start non-invasive ventilation fail, and as a result of the failure, they have to be intubated. The vast majority of patients who have ARDS really need to be intubated because they need high levels of PEEP to actually unflood the alveola. Part of the problems with ARDS is that the alveolas are flooded with fluid. As a result, gas exchange is very poor, so they're constantly in a hypoxic state. There are some potential complications from intubation. Sometimes it takes a long time to intubate someone, and this creates a prolonged hypoxemic effect on the patient. Some patients aspirate gastric content when they're intubated. Some patients, they have a misplacement of the ET tube. It doesn't go down the trachea, it goes down the stomach. And sometimes when a patient's on mechanical ventilation, who's in ARDS, there's a hemodynamic compromise. So sometimes you have to do some fluid administration to keep the blood pressure up. And these are very important steps. Also, when you use high levels of PEEP, you actually decrease cardiac output, and this potentially could be another problem. Let's do a case study for ARDS. We have a 40-year-old HIV male with bilateral interstitial infiltrates. He's transferred to the ICU and put on a venti mask at 10 liters per minute. They suspect the patient has PCP, pneumonia, and they start treating the patient empirically with Bactrim and prednisone. His vitals show a blood pressure of 112/70, a heart rate of 110, his SATs at 94%, and his respiratory rate's 28. So he seems somewhat stabilized. 2 hours later, the patient is noted to be lethargic with a SAT of 77. Some things are happening. The fellow in the ICU decides to intubate the patient, and they put him on a ventilator. The initial settings are assist control of 500, rate of 14, PEEP of 5, FiO2 of 100%. They do an ABG in 30 minutes, and the pH comes out to be 724, PCO2 is 42, PaO2 is 60 on 100%. So if you calculate the PF ratio, it comes out to 60. So what do we have? Do we have acute lung injury or do we have ARDS? You tell me why. You should be able to calculate this yourself, and this is something that you should be able to carry to the bedside when you're working with patients. They decide to do an x-ray on the patient, and when they do the x-ray, they notice the bilateral opacities. The patient has some capillary leakage, some vascular permeability. So this is a typical sign of ARDS. They also conducted a CAT scan on the patient, and the patient was in the supine position when they did this. What I want to point out to you is that there's so much collapsed alveoli, and you could see that, and I'll draw this for you. You see all this area right here that I'm circling? This whole area is not taking place for gas exchange. The only area taking gas exchange is this area up here, which is not doing the best job in the world. All of this area over here is collapsed alveolar with fluid. Believe me, they're not taking any kind of gas exchange. So what would be a good point to do with this patient at this point? A lot of times proning them is the correct thing to do. So they're right now in the supine position. You flip them over and you put them on the prone position, and you do that for anywhere from 12 to 16 hours to get some kind of response to that. I wanted to share with you an approach to managing patients with ARDS, and this is called the open lung approach to ventilation. This involves high levels of PEEP in combination to low levels of tidal volumes as a lung protective strategy. The goal is to use low tidal volumes in the range of 4 to 8 milliliters per kilogram and limited plateau pressures under 30 centimeters of water. It is now widely considered the standard of care in acute respiratory distress syndrome. The open lung concept was a proposal to use recruitment maneuvers followed by higher PEEP to reduce atalic trauma and shear stress injury. A universal accepted protocol for open lung ventilation does not exist. Everyone has their own ways of doing it. You could use APRV. You could also use high-frequency oscillator ventilator. You could use also the ARDSnet protocol. All of these strategies use the open lung ventilation strategy. In regard to recruitment maneuvers in ARDS, this is a great way of actually opening the lungs, followed up by high PEEP, and my next few slides will talk more about that. So I wanted to talk about some of the potential benefits of the open lung ventilation strategy in ARDS. First of all, it maximizes recruitment of the alveolar by preventing derecruitment. It also minimizes cyclic atelectasis and atalic trauma. It also minimizes barotrauma and biotrauma from alveolar collapse and the release of pro-inflammatory mediators. It minimizes denitrogenation of forming of atelectasis, and it avoids oxygen toxicity because you're allowed to use lower FiO2s with higher PEEP levels. All of this adds up to better control of the patient and actually protecting the lungs. Let's talk about recruitment maneuvers. I am sure you all have heard of it, but not many respiratory therapists actually do it. I don't know why they don't do it because the evidence is strong to support it. Basically what it is, it's an administration of high ventilatory pressure to a patient for a brief period. For example, you will use a high PEEP of 40 for 40 seconds, or you would use a high inspiratory hold with a peak pressure of 40 for 40 seconds. The goal is to reinflate collapsed alveolar and then keep it open by the application of PEEP at the end. So if you are doing a recruitment maneuver and you're doing it correctly, and then you don't adjust the PEEP at the end of the maneuver, you just did this for nothing. The lung will de-recruit and you'll have collapsed alveolar. So the goal is to use a high pressure for a short period of time, an inspiratory hold, and then applying PEEP at the end. When I say PEEP, I'm not talking about a PEEP of 5 or 10. I'm probably talking about a PEEP of 15 to 25, all based on the type of patient you're using it on. The desired outcome of a recruitment maneuver is to improve oxygenation, and there are different types of ways of doing it, which I'll explain some basic types. There are some contraindications to a recruitment maneuver, and some of them are hemodynamic compromise, if you have existing barotrauma, if you have increased intracranial pressures, or you have a predisposition to barotrauma. So what happens is when you start a recruitment maneuver, you have so much PEEP, so much pressure on the lung that it impedes venous return, thereby compromising cardiac output. So basically, you need to be hemodynamically stable. If you have any kind of existing barotrauma, like a chest tube, that is contraindicated. If you have increased intracranial pressures, that's another contraindication. Or if you have any kind of bolus lung disease or any kind of focal lung pathology, such as a lobar pneumonia. All of these are contraindications to the use of a recruitment maneuver. So let me explain some of the common recruitment maneuvers that are used. This one, called manual hyperinflation, originally was used when this concept first came out, but it's not really used anymore too much because everyone's got high-end ventilators. Basically, how you do it is you clamp the ET tube at the end of inspiration. You attach a bag valve with a PEEP valve to it, and you basically set the PEEP anywhere from 15 to 20, and then you keep that PEEP valve on the patient for anywhere from 20 to 30 seconds. And then you perform this maneuver every 2 to 3 times, and then the patient is put back on a ventilator at a higher level PEEP of 15 to 20. So the goal is to inflate the lung, hold that inflation with a PEEP valve for about 30 seconds, then put the patient back on a ventilator at a higher PEEP level of 15 to 20, but you do this maneuver 2 to 3 times, and it really works rather well. The second type of recruitment maneuver can be done with pressure control ventilation, and the goal is to create this prolonged inspiratory pause. So basically, you have a patient on pressure control ventilation, you set the peak inspiratory pressure to 40, and you actually do an inspiratory hold for 40 seconds at an inspiratory pressure of 40, and you repeat this 3 times. And then, most importantly, when you put the patient back on normal ventilation, you have to use increased levels of PEEP, typically in the range of 15 to 20, and this way the patient won't de-recruit. But this is another great maneuver to do too. This is the third PEEP maneuver, and it's actually called the PEEP maneuver. Basically, you increase PEEP to 40 centimeters of pressure, and you keep that PEEP on for 40 seconds. You use a low tidal volume strategy of 4 to 6 cc's per kilogram based on ideal body weight. And again, you do this maneuver 3 times, and then you place the patient back on a vent with normal mode, but you actually lower the PEEP or keep the PEEP in the range of 15 to 20. That's called the PEEP maneuver, and they all accomplish the same thing. They're all open lung ventilation strategies with a recruitment maneuver, and they do work. To show you how well a recruitment maneuver works, the best way to look at it is through an X-ray. On the left is a patient who did not receive the recruitment maneuver yet, and then on the right, there's the patient, the same patient who received the recruitment maneuver. You could see the area of aeration has greatly improved after the maneuver. The most important part, again, is you need to return the patient to a higher level of PEEP. Don't put them back on a PEEP of 5 or 10 because it won't work. But it really works, and you'll also see an improvement in the PF ratio. When you're talking about ventilating a patient with ARDS, there are various ventilators out there, and there are various modes. No particular ventilator, no particular mode has been shown to be superior to another one. Basically, it's how good the therapist is using the ventilator. Some of the proven strategies was the ARDSnet protocol, which I'm going to get into a little bit later. Another proven strategy is the use of APRV. APRV is the name used for Draeger ventilators. Bivent is the one used for servos. Bilevel is the Puritan Bennett. And DualPAP is the one used for Hamilton ventilators, but they're all the same strategies. I'm going to talk about adult high-frequency oscillator. I'm going to talk about the use of nitric oxide, and I'm going to get more into the concept of prone positioning for patients with ARDS. Patients with ventilators are sometimes subjected to what is known as ventilator-induced lung injury. This occurs, especially with the ARDS patients, when they receive excessive tidal volumes that actually create a series of pathophysiologic changes in the lung wall. What happens is the initial volume trauma in the alveolar units creates a series of changes that occur. The ARDSnet protocol first identified ventilator-induced lung injury as a major problem. And the cause of this is basically high inspiratory pressures, and this actually promotes alveolar overdistension. And then the other thing is that the alveolar are exposed to what they call shearing pressures, which means they are open and closed, and sometimes they rupture. These ruptures, or these small lesions in the alveolar, actually trigger an inflammatory response where all cytokines and chemokines are released in the body, and this causes a generalized inflammation. This generalized inflammation could result in multiple organ dysfunction and death. So when you manage a patient who is in ARDS, you really got to be cognitive of the tidal volumes you deliver to them. I want to introduce you to a very important study, and it's called the ARDSnet study, and it was actually done back in May of 2004, and it was published in the New England Journal of Medicine. What they were looking at was patients with ARDS, and the goal was to determine what kind of tidal volume and PEEP would be best for this group. So what they did is they randomized two different groups. One group received a tidal volume of 10 to 12 cc's per kilogram with, I would say, normal PEEP. And the second group, they received a tidal volume anywhere from 6 to 8 cc's per kilogram, but they used a higher level of PEEP. And when the study was being conducted, they found rather quickly that the group that received the low tidal volume, high PEEP, actually had a much lower mortality rate than the group that was receiving the 10 to 12 cc's per kilogram tidal volume with normal PEEP. So they stopped the study because the evidence was overwhelming. So from that, they developed this table. And the table shows that you really want to use higher levels of PEEP and lower FiO2. So how this works is this. If you're on 30% FiO2, you could get a PEEP of 5. But if you start going into 40% FiO2, you really need to bump up the PEEP up to 8. And once you get into 60% FiO2, you really need to bump it up to 10. And as you can see from the table, it keeps on going higher and higher. There's no way you're going to have someone on an FiO2 of 100% with a PEEP of 8, because that just doesn't make sense. The ARDSnet protocol is greatly followed by many physicians. It's well known, and even today we follow that very closely. Sometimes, instead of using a 6 to 8 cc's per kilogram tidal volume, they actually use 4 to 6. All depends on the patient, and the goal is to use low tidal volume, high PEEP, and the mortality improves, and actually the outcomes improve. So you should really have a good handle on this. So you have a patient with ARDS, and you want to know what kind of tidal volume to set. Actually, no particular mode is better than another mode. So SIMV, assist control, and so on. The best modes are how you manage it, how the therapist manages. So the ideal tidal volumes you want to use or anywhere from 4 to 6 cc's per kilogram. And the reason for that was there was a greater reduction in mortality in these patients. With a lower tidal volume, you can expect that you're not going to blow off as much CO2. So what happens is your CO2 is going to rise. So this is what they call permissive hypercapnia. Permissive hypercapnia is an acceptable thing, especially with a patient with ARDS, because you don't want to over-distend the lung and you want to use low tidal volumes and high PEEP. I cannot overstate the importance of PEEP in the management of patients with ARDS. High PEEP can improve the PF ratio versus low PEEP. PEEP is an easily implemented intervention that is primarily used to prevent atelectasis and to correct hypoxemia caused by alveolar hypoventilation. Some studies that supported Borges show that the recruitment maneuver with PEEP and subsequent maintenance of high level of PEEPs reversed collapsed alveola and improved oxygenation. Another study done by Putinson showed better outcomes with routine use of low tidal volumes but with high PEEP, and these patients actually did much better too. And recently, the alveolar recruitment for ARDS trial found that patients with moderate to severe ARDS, a strategy of lung recruitment and titrated PEEP compared with low PEEP, decreased 28-day mortality. The studies are overwhelmingly positive for the use of PEEP. Basically, PEEP prevents the collapse of unperfused alveola. It keeps them open. It actually prevents cyclic opening and closing damage to the airway, and it may also prevent biotrauma from ripped alveola. A problem with it, it could cause overdistension and barotrauma, so you really need to know what you're doing when you apply PEEP. What's the role of an IE ratio with a patient with ARDS? We're all familiar with IE ratios. A typical IE ratio is 1 to 2 or 1 to 3 or even more, depending if the patient has obstructive lung disease. With ARDS, studies have shown that when you have a longer inspiratory time, it increases intra-alveolar mixing and it improves CO2 removal. So basically, patients with ARDS would do much better having a longer I time, like 1 to 1 or maybe possibly 1.5 to 1 or 2 to 1 if you do an inverse IE ratio pressure control ventilation. If you use a short I time, you're going to more or less create more harm to the patient by decreasing their oxygenation status, and that's not what you want to do. I wanted to tell you a little bit about some studies that were done with the use of APRV, and they actually did a study of APRV versus the ARDSnet protocol, and this is for patients with ARDS. Both of these strategies, APRV and ARDSnet, are open lung ventilation strategies. Both of them minimize ventilator-induced lung injury. The idea is to keep the plateau pressures less than 30 centimeters of water. But when they compared APRV versus ARDSnet, the finding was that the mortality was the same, but there was fewer inflammatory mediators were present with APRV. So it looks like APRV actually created less damage to the lung with the resultant inflammatory mediators being released. Something to think about. I am sure you all have heard of the high-frequency oscillator. The high-frequency oscillator ventilator has been a heaven-sent tool for the babies. It actually has improved mortality and it's done wonders. So they tried to use the adult high-frequency oscillator with patients with ARDS. 2 studies were done in 2013, one by Duncan Young et al. And the other one by Niall Ferguson et al. And both of those studies showed an increased mortality associated with the use of the high-frequency oscillator ventilator, and they feel that the low tidal volume strategy may be the best bet to use with these patients with ARDS. So the high-frequency oscillator ventilator did not work too well for this group. With the use of ECMO, ECMO can save lives, but a recent international trial showed that patients with very severe ARDS, the 60-day mortality was not significantly lower with ECMO compared to conventional mechanical ventilation strategy. So basically, if you manage a patient very well with mechanical ventilation, and you don't need ECMO because the mortality rate will be the same. So what is the role of inhaled nitric oxide with ARDS? Studies have shown that it does improve oxygenation in over 60% of the cases. It does that because it's a pulmonary vasodilator. It improves VQ mismatching. The problem with it is that the overall mortality is the same. So it will improve your oxygenation in a short-term basis typically for 2 to 3 days. But the likelihood of you coming off the vent is the same if you didn't use it. And when you consider the expense of inhaled nitric oxide, you might want to say you're not going to use it. These are tight times and you really need to conserve your resources. This is a perfect picture of a patient with ARDS, and this is an actual CAT scan, and it shows all collapsed alveoli at the dependent region of the lungs. For example, I'm going to show you the circle. All of this area right here is collapsed alveola, and that part of the lung is not taking part of gas exchange. The area on the right, this area right here, is taking part in gas exchange, but it has a bunch of infiltrates. So the goal is, what kind of strategy can you do besides high PEEP, besides APRV, in managing this patient? And the simple answer is you could prone the patient. There is strong evidence that proning of a patient is an excellent tool to improve oxygenation. And it does this by you flip the patient over into the prone position, and the pleural pressure is more evenly distributed to the dorsal regions of the lungs. What that means is that the patient now can aerate and oxygenate parts of the lungs that couldn't open before when you were in the supine position. It improves oxygenation in over 70% of the patients. It typically occurs within minutes, but you got to use it anywhere from 12 to 16 hours to get the real benefit of it. You cannot put a patient on a prone position for 1 hour, then flip them back. If you're going to do it, you're going to do it for many hours, such as 12 to 16, which is commonly done in the field. I just wanted to show you a very poor picture of the prone position. This is not the one you would see in the ICU, so you know what you got to look for in the ICU. So one of the things you really got to look at is if someone has ARDS and the likelihood they're going to be on a ventilator for a long period of time, they could get VAPS, ventilator-associated pneumonia. Nosocomial pneumonia is greater in ARDS patients. All studies have shown that the longer a patient is on a ventilator, the greater chance they're going to get a VAP infection. VAP risk increases 3% every day in the first week. VAP is associated with increased mortality of 20 to 30% on top of the ARDS. So you really need to identify if someone has VAP. You need to do some diligent airway hygiene, and you've got to do everything you got to do to prevent it to happening. In 2024, they came up with some new guidelines for the management of adult respiratory distress syndrome in adults. And some of the recommendations they have made, because the last recommendations were made in 2017, so some of the newest recommendations they made were the use of corticosteroids, as also use of VV ECMO in severe cases of ARDS. Other suggestions was the utilization of neuromuscular blockers and also using higher PEEP levels without doing a lung recruitment maneuver. So this is sort of new recommendations that came through in 2024, and I'm going to actually build a new presentation that goes into much more details about these factors. But I'm going to give you a little bit of information that came from these recommendations, which all started in 2024. So let's get a little bit deeper into the use of corticosteroids with ARDS. We all have heard of corticosteroids, that they are a great anti-inflammatory medication because they inhibit the synthesis of these pro-inflammatory mediators that are present in ARDS. These same pro-inflammatory mediators were found in COVID patients, and they have found that when they use corticosteroids with COVID patients, it actually reduced mortality in this group. So what they did is they did this, they evaluated 19 different randomized controlled trials that had a total of 2,790 patients, and they looked at the total effect of corticosteroids with these patients. And a pooled analysis demonstrated that the patients that received the corticosteroids had decreased mortality, decreased mechanical ventilation days, and decreased hospital stays. Now, there are some risk factors going along with corticosteroids, such as hyperglycemia. Also, you can have some GI bleeding, and also sometimes you can have neuromuscular weaknesses. But with all of this, they felt that corticosteroids was a pretty good drug to use on these patients. So some of the newest recommendations for 2024 is to use corticosteroids with certain patients with ARDS. And in the past, they sort of frowned away from it, but the study with COVID patients more or less reinforced the use of it. So what about the use of VV ECMO with patients with ARDS? In 2017, the ATS guidelines addressed the issue of VV ECMO with patients with ARDS, and they basically found insufficient evidence to make a recommendation to use it or not use it. So they really didn't understand much more about it. But since that time, they did many multi-center randomized controlled trials, and they evaluated the effect of early initiation of VV ECMO with patients with severe ARDS, and they published their findings. So from these findings, they felt that it was a good way to reduce mortality and increase ventilator-free days, and also decrease the use of vasopressors-free days. So there's some good evidence for the use of VV ECMO in selected patients. You may not know much about VV ECMO, but VV ECMO is a device that oxygenates blood and also removes CO2 in patients with ARDS because it drains the blood from the venous system. It passes through this device, and during this device there's some gas exchange, and where they take out the CO2 and they replenish the oxygen, and they don't really damage the lungs at this time. So it's really basically a very invasive procedure. It's also resource intensive. In other words, it takes some very skilled people to use this technology because it's not just the VV ECMO device. You need to manage the ventilator in a certain way, low tidal volume strategy. So it turned out to be a pretty good thing, and it's a new recommendations based on 2024. There is some safety concerns, and those safety concerns are an increased risk of hemorrhage, and also one of the positive things, there is really no risk of getting a pneumothorax with this type of procedure because you use this low tidal volume strategy. So this is a new recommendation for selected patients who have ARDS in the 2024 guidelines. Like I was saying before, I wanted to consider putting together a new presentation on this, and I don't want to spend so much more time with this, but there's two more considerations that you need to understand. First of all, should a patient with ARDS receive neuromuscular blockade? And the second question is, should patients with severe ARDS have higher PEEP levels than what has been recommended in the past from 2017? And one of the key points is, at one time, they used to talk about a lung recruitment maneuver on ARDS patients. And during this study, they looked at the use of high PEEP levels without a lung recruitment maneuver. So I'll get a little bit into this, but I don't want to spend too much time with this. So this is a summary slide from the recommendations from 2024. And the difference between 2017 and 2024 is the introduction of use of corticosteroids, also the use of VV-ECMO, and also the utilization of neuromuscular blockers, and also high PEEP. So I talked a little bit about corticosteroids and VV-ECMO, but I didn't really go much into the neuromuscular blockades. And basically with the neuromuscular blockades, it's used for early cases of ARDS, less than 48 hours of mechanical ventilation. Also, you need to have a PF ratio less than 100. And they believe that the utilization of these neuromuscular blockade agents would reduce mortality compared to deep sedation normally found with patients with, who are on mechanical ventilation. They're deeply sedated. So they actually showed some reduced mortality. And then the utilization of high PEEP, they looked at patients who had a PF ratio of less than 200. And their recommendation at this time in 2024 is that you can use higher PEEP levels, but you need to look at hemodynamics. Make sure that, when your PEEP levels are so high that your venous return is not dropped and your cardiac output is not dropped. And also, you need to not really do many prolonged recruitment maneuvers. Some of this is new evidence coming out in 2024. And like I said, I might put together a more detailed presentation on this. So these are some of the updates, and this is a summary sheet from that findings. So in summary, adult respiratory distress syndrome and acute lung injury are not going away. It's here today, it was here yesterday, it'll be here tomorrow. ARDSnet strategy, where you use a low tidal volume, high PEEP strategy, seems to work. It seems to be the holy grail of management of ARDS patients, but there are some other implementations that point to the use of corticosteroids, also with VV-ECMO in certain patients. I talked a little bit about the contraindications of VV-ECMO, where you really need to have the expertise to go along with it, and it's very resource intensive. The use of neuromuscular blockades is really good for less than 48 hours on mechanical ventilation, and then higher PEEPs without a recruitment maneuver is being researched, but they're saying it sort of points to a benefit with certain populations. I want to thank you today for joining me in my conference. I hope you really enjoyed it. I know you're going to be dealing with patients with ARDS, and I hope that the information I supplied to you is helpful. I listed some references for your review if you ever want to go into a little bit deeper in understanding ARDS. These are some very good listings, and you have a great day.